Hello, Susan Reynolds. I am the chapter social worker for HDSA, and I currently serve both Orange County and San Diego counties in Southern California. I'm delighted to be here. Prior to moving to California 8 months ago, I was the chapter social worker, not the chapter social worker, the Center of Excellence social worker at University of Washington Medical Center in Seattle. I've worked in home health and hospice and now Huntington's for about 35 years in the state of Washington. So long-term care planning is my passion, so I'm thrilled you're here. I've got a lot of information. It's all on the slides. This will be recorded. So we'll hold questions to the end or comments, and I may move a little bit quicker through some of the material because what's available in one state may look a little different in your home state. So I bring those 35 years from Washington and California. So thanks for joining. It's great to see. How many people at your first convention? Oh, welcome. And I bet I saw a lot more hands virtually. So again, we welcome our virtual participants and all of you. Thanks so much. Okay, so hold on just a second. We got a little, bear with me just a minute. We're having a little bit of, okay. There we go. So this presentation is really geared toward people living with HD as well as families. And when I talk about long-term care planning, I think it's something that all of us, whether you are from an HD family or diagnosed gene positive, need to know about. Because throughout the course of life, 95% of us are going to need care of some type, either short or longer term care at some point in our lives. So I think this is essential for all of us. So we're going to cover a lot of topics about it. And again, this information is educational. Most of it is from my 35 years of experience as a social worker, and as well as research and learning from families like yourself and other professionals, some who are in the crowd today and others that I'm just meeting. So make sure that if you have questions that are related to medical care, check in with your primary care, your HDSA Center of Excellence teams, because I'm not here to give any medical guidance, although I've learned a tremendous amount from my colleagues. Finally, we just ask that everyone wear a mask. We want to make sure that you're all safe and that we all go home safe, and thank you for following through with that. And finally, we're going to have questions, and all those questions will go through the app. So if you have any trouble with doing that, make sure that Virginia here, who will be back in a sec, will help you with that. And there is a little packet in your folder. So let's begin. I really like to make sure that people understand kind of some of these key terms we'll be talking about today. So the key ones are going to be defining what long-term care means. Some of you may have a different or expanded definition. That's okay. I'm sure you'll share it with us. Develop an understanding of why it's important. What do we need to do this long-term care planning for? How's it going to benefit us or our families now or in the future? And finally, I'm going to share some local and national resources with you. And fortunately, being a part of the HDSA community, there are social workers like myself all over the country who are also available to you depending on what state you're from. And if you don't know that, you can check with me and I'll make sure that gets passed on. So, what is long-term care planning? This is kind of the standard definition that I have used consistently over the last many years. And really, it's a variety of both medical and mostly, I would say, non-medical services and supports that will be necessary to help care for individuals who have a chronic illness or a disability, and again, over a short or prolonged period of time. My first job out of graduate school was as a nursing home social work director. That was 1 month after grad school, I was promoted to directorhood. Well, I didn't even know what that meant then. So it was quite an accomplishment and quite a learning curve, and that's where I really started my learning about long-term care planning. We know that people who are affected with HD will, at some point over the course of their illness, require care. And some of you may be those caregivers now, you may be those caregivers in the future, and you may also require to have other people assist you with that care. So we're going to talk about care in the home, or what's called home-based services. We're going to talk about what's out there in the community, what's available if we cannot do it all and we need to get other people involved so that our family member can be at home as long as possible. And finally, we're going to talk about opportunities for placement in community-based facilities. And I find that that is one of the most difficult ones that I have encountered for families with HD. So I know we have a couple of experts in this room who have worked extensively in this field, and I think we'll learn more from them and as well as from you about what's important to think about and look at as you move forward. So let's start at the beginning. What we've all been doing ever since we got together, communicating, talking with each other, learning from each other, and particularly when you're living and dealing with a chronic illness or a disabling condition, it's really important in my professional as well as personal opinion, because I've sat in an audience, not with HD, but with other illnesses in my own family, about what you hope to happen, what may happen, and where to turn when those needs arise. And one of the things I have found is that families have come to me and said, you know, Susan, I promised that I would always keep my family member at home. I love them, I'm going to do it, and now I find I can't. I either have my own issues, they have so many issues that I can't do it all by myself. So the one thing that I want to encourage you is to always be as mindful and as thoughtful as you can when thinking about long-term care planning. Be realistic about who you are, what you can do. Already today, I've heard people say, you know I'm not the caregiver. I care in so many other ways. My sister is the most amazing caregiver. She's there day in and day out. So be aware of what you can do and what you may need help with others doing. Also remember, with Huntington's, we know that it's a slow, progressive disease, and it causes change over time. And so when I came to Huntington's disease, I had worked in the field of hospice for 25 years. And with hospice, I might get one chance, 1 hour, 1/2 hour with a family, and that was it. And so I came in with that perspective to, okay, we got to find out what you want, what's your paperwork in order, what support do you need, what does your family need? And my colleagues, and that's why I love working at a Center of Excellence, said, slow down, Susan. It's really important. This is not a fast disease. Think about your marathon running. I was a marathoner once upon a time. And so I really had to look at my own mindset about making sure that I gave people all the information in the hour that I had with them, which is why I have so many words on the screen today, because I was thinking of all of you, and I wanted to tell you as much as I could. This is a process. This disease is a process, and so you won't learn everything that you need to know today, but hopefully some seeds will be planted, and you will have information that will help you go forward as yourself or your loved ones' symptoms develop and change over time. The other thing, I think, again, is just staying flexible as a family. Somebody said today, you know, that when that stone drops close to you in the water, it's really heavy. And I think, you know, sometimes the stone drops and it cracks, and sometimes the stone breaks. And as a team, as a family, as friends, as a community, we're stronger together. So I think it's really important to think about how you work together and stay flexible as you can. So I'm going to give a couple case examples. These are usually ones that I have about 5 different people that I've worked with in my mind. So Ronnie's 32 and has been considering testing because Ronnie got married and wants to have a family. His mom has symptomatic HD and his sister has also tested positive. So why does Ronnie need to think about long-term care planning? He's just getting going in his life. He's young, he's at risk, but he feels great. He's got this exciting future. He is part of an HD family, though. And so I've outlined a few things that I think would be helpful for Ronnie to think about. And one of those things Ronnie knew was that he needed to start talking to his spouse about his thoughts about testing and what that would mean for him as well as for both of them. So that was kind of a starting place. Also, Ronnie's fortunate, lives in a state where there's a center of excellence within an hour of him. So thinking about contacting the center of excellence about predictive testing, another part of that planning. And equally important, beginning to look at insurance options for himself, his family, so that if he decided to go through with testing, he would have the opportunity to have obtained insurance if that was something he decided upon. Also, as much as possible, because you see his mom is already having symptoms, his sister is positive, we don't know where she is in her thinking about this, to begin that communication with his family about what his thoughts are. And so those of you in this room today may have people in your own family that don't want to talk about it. It's like hands up, keep away. Even sometimes in medical settings, I find that there are clinicians that say, well, let me get somebody for you, or they'll call you, or they'll follow up. And it's well-intended, but they may not be ready to have that conversation. So for Ronnie to be thinking, who do I want to talk to? What's going to be important? Ronnie and spouse thinking about looking at options for PGT, pre-implantation genetic testing, and in vitro fertilization. So another option that's now available that wasn't available for a lot of families. Whether it's cost affordable is another matter, but knowing that there's information out there now that there wasn't in the past. Also, the other issue Ronnie's dealing with is his family and beginning to learn about resources for his mother and his sibling and planning and communicating. So, case number 2, Meredith, she's 45. Her symptoms have progressed to the point she can no longer work. She is also already on Social Security disability. She's still living alone, but she's getting help from her family with her finances because cognitively she's having challenges managing. They're preparing meals and bringing them over. She started having swallowing difficulties, so her family is providing more assistance with not only preparing meals, but cutting food up. And she started having falls at home. So her family is talking amongst themselves about bringing help into the home and talking with Meredith about establishing something called advanced directives. We'll go into more detail on that toward the ends of the presentation. One challenge here, they haven't talked to Meredith about this yet. So Meredith is living alone. Even though she's got this support of her family that's doing some caregiving, she's very happy to be at home. And so this is a big deal to her family. So what are some long-term care planning steps? Well, one thing that can be very helpful is that the family and/or Meredith, if she's willing and interested, reach out and get some advanced directive resources. The Centers of Excellence, social workers, local websites, national websites, 5 Wishes, different things like that are available so that people can have talking points as they begin to have the conversation about advanced care planning and the documents called advanced directives. And then setting up a time to talk about advanced directives. This family's feeling a lot of pressure. They want Meredith to be her own decision maker, and yet they're realizing that she's becoming more symptomatic, and they want her to be able to express what her wishes are while she's able, because once we lose the capacity to make our own decisions, then somebody else has to step in. So again, they're wanting to empower her, but they're thinking about how do we begin this conversation. Last, but consulting with the Center of Excellence doctor or her PCP during a visit about having a home health evaluation. So I mentioned one of my hats I wore was as a home health social worker for many years. And so there are teams that are covered by Medicare or other insurances, Medicaid, private health insurances, where a nurse, physical, occupational therapist, social worker can come out, speech therapist can come out to the home to do an evaluation and develop a treatment plan so that recommendations can be made about safety, the home environment, those sorts of things. Also, checking in with the Center of Excellence social worker, or if there isn't a social worker at the time, the chapter social worker or the area agency on aging that all communities have on is she eligible for help if she decides to go that route? And what does that look like financially? There are programs through states called waiver programs, so that might be something that Meredith can be eligible for. She's pretty young to already be symptomatic, and so the family and Meredith can explore that. And then finally, beginning to explore costs of long-term care. Again, what are those waiver programs? What are private pay options? Knowing what community facilities are out there, because as I've been talking with people throughout the weekend, we've already heard folks say, there's nothing in my community. Nobody wants to take someone with HD. Where do we turn if we can't stay at home any longer? We need someone to care. So those are, again, to me, very important communications to have earlier on. And finally, John. He's 59. John is in the final stages of HD. He's now completely wheelchair dependent or in his bed when not up. He's falling out of his chair, and he is completely incontinent. He's unable to manage his bowel and bladder at this point. His spouse has been his full-time caregiver, and she can no longer manage his care. Not only is he completely physically dependent, he's become aggressive the past few months over the spouse, and she cannot do it any longer at home. And so this is a situation that some families I've worked with have found themselves in, and at the Center of Excellence or now at the chapter, we get a call, help, I need my loved one to go somewhere. I can't take care of them anymore. This is the hardest place I have found to start from, and yet, honestly, many families have started here because of those promises that were made. Or again, as someone said earlier today in a presentation, I was the caregiver all the time. I didn't see the changes happening. I didn't even notice that my parent had become advanced, and suddenly I was doing everything for them. So I always hope that we've had these conversations from stage one and case example 1 and 2, but it's not always possible. So again, what to do? So to the spouse, I say, contact the Center of Excellence where you've been going and or your primary care if you're not connected with a Center of Excellence, because sadly, there are people that are not able to access. Get a hold of someone in your medical team and report the symptom changes, because sometimes there's treatments that can help with some of those behaviors, like aggressive behavior. Sometimes, again, there are programs that can be referred to, a home health evaluation to help see if there are ways to make the home safer until a plan can be set up. And then get those resources. Again, what's help in the home? This spouse has been caring for her husband all along, so she's never brought anybody else in. And so what else is out in the community, and then what placements are out there? As you all may know, some of you or not, that some places have long waiting lists, and so there's not always the variety of placement available. And so I always like to tell people it's great if you only have to ever move once, if you do have to move. We know that's not always possible, though. So again, to the extent possible, use those professionals in the community. If you're part of a support group, use your other support group members who may also have ideas. One of my caregiver support groups, people are constantly saying, hey, I went to this place, don't ever go there. Here's a place I went, this is pretty good. Here's a couple of other people you can talk to. So communication is essential. Okay, so let's move into community-based services. Excuse me. So you remember our person from case number 2, living alone, having falls. There's something in the community called a life alert. You know the commercial, help, I've fallen and I can't get up. That's called a personal emergency response system. When I started in home health, I think I could have gotten stock in this company and I'd supply everybody with them. But what it is, it's a alert system. You wear it around your wrist and or like a pendant. I used to tell people it's about the size of dog tags, just to give you perspective. They're waterproof, and it's great if somebody lives alone and or they live with a family member, but that family member's away at work all the time, because it's lovely to say, well, have your cell phone. Oops, it hasn't broken yet when I do that. That's what can happen, and as quick as that, my lifeline is cut off. And I didn't even have one of these when I first started in home health, so it was the cord phone, and usually somebody fell in the other room because we didn't carry our phones with us. So this is a great little tool. They usually run about $35 to $50 a month, depending on where you live, and they are set up so that someone can respond to come and check on you that lives within 15 minutes, or if no one is available on your emergency list, it goes actually to a 911 for check. So a simple yet important tool. Now, I use the generic term Meals on Wheels. That's actually a formal program for individuals over the age of 60 or younger who pay full price. Meals on Wheels are programs that are voluntary payment for older adults. For younger adults, they do charge the cost of the meal. For a lot of people, these are lifesavers if they can no longer prepare food. They're cutting themselves, but they can still heat something up in the microwave. And so this type of meal program, and there are many others depending on where you live. In most rural communities and large cities, though, we do see the Meals on Wheels program. I did notice during COVID they got really backed up because they had more and more people who could no longer get out at all, and so we saw waiting lists like I'd never seen before for the program. So a meal program can be very helpful if you as a caregiver or family member aren't able to do that. Adult day health programs, because I did home health and hospice for so long, I learned about these early in my career, and these are programs where they're on site at a center where they offer both structured activities, food, recreation, socialization, and they transport people from their home there and back. Most of these programs that I have worked with are funded through Medicaid, or if anybody here besides me is from California, Medi-Cal. However, I also found out over the years that the Veterans Administration, for people that receive veterans benefits, may be eligible to have them pay for this. And then finally, people can always pay privately. But this allows, let's say you have your family member at home and you are working during the day, or you simply need time off during that day. With an evaluation for this program, and they're found eligible and can come anywhere from 1 to 5 days a week. Your family member can go there, you can do what you need to do and take care of yourself, and then they're brought home at the end of the day. So these can work very well. When I found they're not as effective is when somebody is so dependent on care they can't transfer on and off the toilet, or they need one-on-one help with feeding, because they have both paid and volunteer staff in these programs. I just visited one in Orange County, and many of their clients also have dementia, so they do a fair amount of hands-on care. However, when it gets to that level, they may or may not be able to accommodate. So just to mention that. And then last but certainly not least, transportation. Anybody in this room had to give up driving? Okay. How hard was that? It sucked? Is that what you said? Yeah. Okay. I heard that loud and clear with a capital S. So this is probably one of the more difficult for people. In working in skilled nursing facilities, I found that people still wanted to drive, and they hadn't driven in 30 years. You know, when I was growing up, you got your permit at 15, you got your license at 16, and I've driven ever since. So imagine you're 20, you're 30, 40, 60, 99, and that's been taken away from you. So knowing what's out there, both public and private services, they're not fantastic necessarily. You're dependent on other people to come and get you. What it can do, though, is it can get you out of the house if you're able, and it also helps for many people relieve that burden of, I'm not going to call Sally because it's 3 o'clock and I know she told me not to call until 5 and I don't want to bother her. So these are public transportation services that can be really valuable. Okay, so we're going to move from those services that you can bring into your home or go to, well, what if I need help in the home with my family member with HD? I can't do the care anymore. I can't tell you how many caregivers have gotten injured over the course of time or had their own health problems, and they've had to stop. So in-home care, it can be provided anywhere from a few hours a day, usually about a 4-hour minimum, I have found with most companies, because of the time for their staff to get there, provide care, and leave. The minimum I've ever seen has been 2 hours, and that was a pretty long time ago, all the way up to a 24-hour-a-day shift care, or what's called live-in care. Live-in care did not work on an hourly basis, whereas shift care you're going to pay by the hour. This is not inexpensive. However, again, it can mean the difference for someone being able to stay at home or possibly move to a higher level of living. And for people that qualify for Medicaid or Medi-Cal, there are waiver programs that can provide. In California, we call them in-home support services. In Washington, we called it COPES Medicaid. It was a waiver program that paid for so many hours of care a month for someone. So people can also pay privately, and veterans programs may pay for this for service-connected veterans. However, that can be a long application process. It's not over days or weeks. It could be months, having worked with many veterans in the past. What I love about home-based care is that a caregiver can help with what I call the independent activities of daily living. Things like shopping, transportation, meal planning, cooking, cleaning. Emphasis on light cleaning, this is not heavy cleaning of the home, as well as care for personal needs. So if somebody needs help with bathing or getting set up for bathing, this is a great resource. Help if somebody's having difficulty with walking, or if they're in a wheelchair and mobilizing that wheelchair. Help with eating, cutting up food, even feeding someone. So this can certainly meet the needs of many people. However, if you're on a state Medicaid or Medi-Cal program, you may be limited to the hours a month of care that you can get. So this may not work for someone who is totally dependent or their family member becomes unable to provide care. The other program that I love, that I used a lot in my work, is called respite care. And respite is literally relief for the caregiver. So I'm a full-time paid caregiver for my spouse, and I don't get out anymore. I've become homebound, not because of COVID, but because I'm afraid to leave them, that they're unsafe. And so the counties have programs called respite, where depending on their qualifications, and sometimes they're income-based, and some counties may even have asset-based. Our county was income-based, where they would provide up to a few hours a week, so like usually 4 to 5 hours a week of a person to come out, or up to 2 weeks in a care center, if there was a care center that they were contracted with. And if I was eligible, then I was not being paid as the caregiver, I'm the spouse, my family member could go, because I'm finally going on that trip I wanted to go to, the convention in Atlanta. So this is a program that can really benefit people if it's available in your county. And you can see the pay sources there. Okay. Anybody ever heard of this program, PACE, or involved with a PACE program? One show of hand, two couple show of hands. So I learned about this through a large organization in Seattle, Washington. It's a program for all-inclusive care for the elderly. So if you think about managed care, so some of you may be on a managed Medicare or a managed Medicaid plan now. So Medicaid is usually the pay source, or Medi-Cal, for these programs. And if you decide to join this type of program, you get a full interdisciplinary team of people. You can see a doctor on the team, nurse, therapies, social work services, staff that work for the organization. You might be getting help in the home, or some people actually go to, again, an adult day health program that is part of their center. Not all centers have that. If someone becomes in need of housing, they can assist with housing. They provide case management. So I know there's at least a couple of us social workers in the room, and we've probably done case management at some times where we've helped that family work with their needs and the goals for their care, and that those are met. So this can be a great program for some people. Some people, however, may not choose to go this way, and here's why. Because they do become the managers of your care, you have to use their medical team. So I had someone join this that was when I was with the visiting nurse services, so I was not with a hospital at that time. And so they had a beloved doctor, and the doctor was different at the PACE program, and they would have had to leave their doctor. So they chose not to do that. I'm working with somebody else now, though, who's really considering this for their family member, because they're no longer able to do all that care, and they really both want a place for them to go and others to help with the care. And so this is a very good deal for them, and they're looking into this. So that's why I have that asterisk about just checking if you belong to a center of excellence. Will you be able to continue with that center of excellence if you belong to a PACE program? So important to know, but also a good option for many. Excuse me. All right, we're going to move to community-based facilities. And again, many of you in this room maybe have had experience with family members with HD, or others in your family. I know while I don't have HD in my family, I have had family members reside in what we used to call nursing homes, and then we came about with the term skilled nursing facilities, long-term care facilities. And so we're going to talk about the different types of care. So I'm going to start with first, adult family homes, or in my state, they're called board and care homes. And each of your states may be different. So if you are a member of an HD family, Your social worker from the chapter or the Center of Excellence will have information about this. These are homes that I've had a lot of younger people with Huntington's disease reside in if they needed to move out of the home. And they're 24-hour, what I call residential care facilities, meaning that you live in a home-like setting that is usually owner-operated. That owner may or may not be a nurse or even a doctor. Most often they're caregivers. They're not necessarily licensed professionals, although there are homes run by licensed professionals. Anywhere from about 2 to 10 other people live in that home, and oftentimes the family lives in it as well, the family that's doing the caregiving, unless they're owned by a small corporation where they have more than one home. I know one home operator in Washington had 20 homes, and so she had staff in each of her homes. And again, those are live-in staff for over 24 hours a day. The thing about them is that, again, these Medicaid or Medi-Cal waiver programs, if someone is eligible and gets a waiver, can pay for those. Now, whether there is a home that is willing to accept the amount that the state that you reside in pays is another matter. So researching what they charge, what they offer is really important. Some people pay private pay and the home is willing. I've seen homes say, if after 2 years you run out of money and you need to stay here, we will allow that, but you have to pay private for a while. So very important to know. I will tell you, having visited probably 200 to 300 of these over the course of my career, that they vary greatly. And word of mouth is very helpful between families with Huntington's disease, because I have met families that have found the dream home, and I've met families that have moved their family member a few times until they've found the best type of setting. People like this type of setting because it is more intimate. It's smaller. You got your own room, although some rooms are shared, and oftentimes people on Medicaid or Medi-Cal don't get that choice, like folks that are paying privately do. So if that's important, that's something to really check out. Also, let's say you have long-term care insurance that you purchased 10 years ago. Will the home accept that? Is it accepted? And is there a waiting period? So is there what's called an elimination or a wait period on that long-term care insurance, which can be usually up to 100 days, and that is not usually waived. I was just with my father this past weekend, hi Dad, and we were looking at his long-term care policy, and I called the company and said, well, what if he becomes terminally ill? Can we waive this 100-day wait period? They said no. When I worked in hospice, though, I had some folks that had long-term care insurance, and that was waived if they went on to hospice. So no policy is the same. So if you've got a long-term care, you want to check and see if that level of care is covered and what that waiting period, if any, is. Another level is called assisted living, and memory care facilities often fall into that category. And so again, these are state licensed facilities, both the adult family homes or boarding care and assisted living. What people tend to like about assisted livings is that it's usually an apartment-like setting. And when I say apartment, that means a large room or a not so large room. But you might have a little kitchenette in it, a separate sleeping area, or a shared sleeping living area. It feels more home-like though, but you're still private and individualized. And then they have a communal dining, living, activity space for people. In Washington State, and I'm still learning this in California, many of those had an entry age requirement of 60 to 65, and so a lot of our HD communities simply didn't qualify. Western side of the state, I had one person in 8 years who went into an assisted living. Eastern side of the state, there weren't very many adult family homes. So the assisted livings, by and large, cared for younger people, which we did not see in the Seattle area. So again, depending if you're from a rural community versus a large city, or there aren't a lot of resources, that's something to find out. The one thing I will tell you about with assisted living, unlike many adult family homes or board and care, is that if someone becomes totally dependent on care, you may be able to hire private help if you can afford that, which is very expensive at $40 to $50 an hour, depending on where you live. But they may not be able to care for people through the end of life. But for many people, for a period of time with their Huntington's disease, that can be a very viable option. So again, if we go back to that thinking, over time, what's important, what gives me the most independence, will I be able to move, and will I want to move? Whereas I've had people that have lived in adult family homes throughout the course of their disease. Excuse me. And then finally, continuing care retirement centers, CCRCs is the shortcut for that. These offer independent living all the way through skilled nursing facility level of care. So again, my experience has been that many of those had an age requirement, back to that 60 to 65 usually, and that oftentimes people were moving in, now I'm dating myself, 35 years, 40 years ago, moving in at 60, like the one I worked at in Hawaii, and then by the time they were 80, 85, they might need a higher level of care. And so they could stay in place and move within the facility. Now I see people at 80, my dad's older, moving into these sorts of places. So he's 89, and he's now thinking, would this be an option or would this not be an option for me? Because most of these places have an upfront fee that you have to pay, and then monthly fees. And it's really important to know what their contract says, because again, many people with Huntington's disease purchased insurance, or they're going to apply for Medicaid if they run out of funds. Well, Medicaid is really complicated, and it has gifting rules, and some of these homes have written into their contracts that if you gift your money away over a 5-year, what's called a look-back period, you may not be qualified, because they want you to pay to live there. So if you give your money away, that could nullify your contract. So that's the long way of saying, be very careful when you're looking at any kind of facility and what you're thinking is going to be most financially viable for you. And I have only seen the CCRCs accept private pay, unlike the other ones that we talked about that can take Medicaid as well as long-term care insurance. Okay, here we go. I jumped ahead of myself a little bit ago. Skilled nursing facilities, nursing homes, long-term care facilities. These are the 24-hour care settings, which are usually much larger. Not always. I did work in a 30-bed facility at one point many years ago. When someone is unable to provide for their own care needs and require full-time care, and this can be people who are experiencing middle as well as more advanced Huntington's disease. Families may not be able to take care of them, or there is no family. They may be having difficulty physically, cognitively, behaviorally, and so this may be an option that is necessary. These facilities, again, are very specific in when people can go. And a lot of people say, well, wait, I got Medicare. Medicare pays for a nursing home. I read it in that red, white, and blue booklet they sent me. Well, Medicare only pays for a skilled nursing facility if you've been hospitalized for 3 consecutive nights and you require daily skilled nursing or therapy care. The first 20 days can be covered up to 100% in a shared room. Days 21 to 100, if you're still eligible, you have to pay a daily rate, and then Medicare pays the rest. People are like, Well, that's not what it said in the book. It actually is. I've read the book from front to back. I don't admit that to all crowds. Anyway, this is something that's very misunderstood. So the only other programs that pay for nursing facility care are Medicaid, again, which have income and asset limits, just like those other types of living that we talked about, Medi-Cal in California, waiver programs, or the Veterans Administration. I've met some veterans already this weekend, and generally you have to have a 70% or higher service-connected disability, and they are contracted with specific facilities. So not all facilities have contracts with the VA. So again, having a VA rep would be very important in this. The difference with a skilled nursing facility, you're going to have a full staff, 3 8-hour shifts, nurses, either licensed vocational nurses or RNs, certified nursing assistants, rehab staff. Again, generally your people on Medicare are going to be those qualified, or you may have some maintenance rehab that's covered under your insurance, a nutritionist, a social worker, and the full spectrum of other staff, administrative and maintenance, that care for the facility. So if you look on that spectrum from least restrictive at home, maybe using some community-based services, in-home services, to 24-hour care, we've just covered all that in, let me tell you, 45 minutes, not bad. So that's the crash course in that. That's a lot about what long-term care planning involves as you're thinking about it. But none of you have to go home today and rush into this. But these are all the things that you get to consider and will want to take a look at over the course of your long-term care planning, because we don't always know what we're going to need. Now, because I worked in hospice and palliative care for many years and advanced care planning, I'm going to talk just a short minute about palliative care. So palliative care is specialized medical care for people who have a serious or life-threatening illness at any stage of the disease. So people that are seeking treatment, people that are looking at what they call palliation or relief from symptoms, pain symptoms, discomfort, challenge emotionally that are causing them distress. Palliative care focuses on what your goals of care are, up to and including treatment. Many people equate palliative care and hospice. They're not the same thing. Some people are on palliative care and may eventually transition to hospice, but not necessarily. So it's really a choice. And back in the last 20 years, we mostly saw palliative care teams only in hospitals. I'm happy to say that depending on where you live, we now also have home-based palliative care teams. Some of them are social work led, and others are a medical staff member, generally an advanced registered nurse practitioner or an MD even. I have seen a couple of places. Again, the team is interdisciplinary. Medical team member, social worker, spiritual care team member, because we're focusing on what your goals are for your life and your care. Funding, I'm so thrilled because we're now seeing that Medicaid is paying for this. In the past, Medicare, and that's why it was usually based in hospitals, and even private insurance. So a wonderful program. I can't say enough about it. I do have a resource for you at the end, the National Hospice and Palliative Care Organization. You can go and learn more about it. This is what I did for 25 years. I worked in the field of hospice. And hospice is truly for end-of-life care that is comfort-focused. It has been determined that there is not a curative treatment for whatever that illness or disease is. And it's focused, again, on palliating symptoms, pain, constipation, agitation, restlessness, those sorts of things. Someone has to have a 6 months or less prognosis or life expectancy to qualify for this program. And many people with Huntington says, now tell me how that's possible. So if you got 10 physicians in a room and you said, is it likely that this person's life could end in 6 months or less? That answer could be yes. We don't know that day or time. This is based on best medical evidence, knowing advanced stages of a disease. I worked with many people with dementia, just like many families with Huntington's, that oftentimes found people were, well, we're not quite sure you're there yet. However, in very advanced stages, this is a wonderful program, and I have found that people sometimes go on it and not because they physically get better, but because they have additional support for their family, for themselves, that their symptoms may stabilize. That doesn't mean they've improved. Their Huntington's has reduced. It means that they've gotten more support. And so some programs, not some programs, all Medicare programs have guidelines that you have to be recertified on hospice over 90 days, 90 days, 60 days indefinitely. And if you no longer qualify, you could be discharged. Now you can go back on that program, though, if your symptoms then continue to increase and you qualify. So that's very important to know. The other thing I love about hospice, it's offered in all types of settings, whatever you call home. Your personal family home, an assisted living, an adult family home, a skilled nursing facility. There are some hospice units throughout the country. So it's a program that comes to you, and it's an added service for the family. It's an added service for the facility. And for all of you in this group that have worked or work in facilities like I did, it's really partnering with that facility team to provide additional care for the person. You can see there are a variety of funding sources, and I come from an area where there was a very rural community on one of our islands, and they actually did not have a hospice team on that island, so they developed a volunteer hospice team. And so, again, lots of places in the country have gotten creative. Mostly, though, just like with medical care, we see major medical centers partnering together. We've seen that with hospice, too. So, finding out, is this a for-profit, not-for-profit? That's hospice. And last but not least, a topic near and dear to my heart, advance directives. So I have an advance directive. I sat down with my husband, and over a course of time, we talked about what's important for us if either one of us became unable to express ourselves or manage our own health care. And we created a document. This may vary by state. Each state has its own rules. Called a durable power of attorney for health care. Sometimes it's called general power of attorney for health care. You have to be at least 18 or older to implement, and you have to understand that you are saying, I am giving someone else the right to act as my agent if I am unable to express my wishes. So if you lose that capacity, folks, you can no longer put one of these in effect, even if you're over 18. So again, my belief with early long-term care planning, this is part of that process. When I did my first one at 32, I was 32. I was really healthy and active, and I was going to, live forever. However, that can change over time, and as long as I retain my capacity, I may decide that the person I chose when I was 32 may not be the person I choose today. I have the right to do that as long as I'm in charge of my decision making. So that person, that agent, has to be somebody that you trust. I believe that you review these over time. If you move to a higher level of care, if you have a major episode, I've had how many people fall and hit their heads, and it's been life-changing. And so as long as they were able to take a look at that, and certainly moving into an alternative living setting, because they all asked, do you have a power of attorney? There's something called a healthcare directive. This used to be called a living will, which was so confusing to people. Some of yours may still say living will if you have them. This is an express direction to your medical team that in certain circumstances, if your life expectancy is considered so short and there's no chance of expected recovery, whether you would want to be put on tube feeding and whether you would want artificial nutrition or hydration. And so we most commonly see the term healthcare directive, but trust me, that's not true in every state. And in my state of California now, that healthcare directive is part of the power of attorney for healthcare. So it's been combined. In the 5 Wishes booklet that many people use, 46 states accept it, it's also part of that. So just know what your state law says. And again, your social worker or your state can give you resources where to find that. And finally, some of you may have this, physician order for life-sustaining treatment called the POLST. In California, is it chartreuse pink? Chartreuse pink. In Washington, it was lime green. What they're a physician order for whether you would want CPR, cardiopulmonary resuscitation, if your heart stopped beating and you stopped breathing. In addition, it has other medical orders, whether you would want comfort-focused care all the way up to extended treatment and care. And you, if you're able, or your power of attorney would be able to implement this document, and then it's kept in the home. And the reason it was put on those bright colors, and when I worked in hospice, was so that if 911 was called, it was hanging over the bed or it was hanging on the door. My mother-in-law at 97, hers hung on a refrigerator. She said, I don't want somebody attempting CPR on me if I were to die. And so this document is something that physician offices have and can talk about. So that's the formal part. I promise to give time for questions. These are some great resources. All of these slides will be available for you. So I have all that advanced care planning, caregiver and long-term care resources, hospice, nursing home compare scores, so you can look at the ratings that facilities are given. The Huntington Society of America, just another recognition of so many resources that we offer. And then I've provided my name and information if you want to contact me. So thank you for being such a great audience. Do we have some questions? Okay.
You can ask those. I'm going to minimize your thing.
It does make sense. The question is, what happens for people, because there are oftentimes long waiting lists around the country for people, and people hold out hope and belief that they can care for someone at home, and suddenly they can no longer do that, and those lists are long. Great question. That is very difficult, and part of the issue is if you're dependent on state Medicaid or Medi-Cal services, there are some facilities that will only accept state, and they may or may not have beds available. Even true with private pay. Now, what I will tell you is I think it's wise to start way back at that very beginning. Remember case example number 1, to begin to learn what's in your community. I've had families that go and visit. They'll put themselves on a wait list. They're not ready to move, but they'll get their name on a waiting list so that if there were changes, and again, generally, this is people that are in more middle stages and they're thinking that they may need to move. They'll get themselves on that list, and if their name comes up and they're contacted, they're like, I'm not ready, please keep my name. Their name oftentimes goes to the bottom of the list. That's one way to do it. The other way, again, quite honestly, is a lot of pavement pounding. And I know that sounds a little bit naive, but I talked to somebody in one of my support groups who went to 30 different facilities. And they went, this was pre-COVID, went because they wanted to tell the story of their family member, their spouse with HD. And so they visited. Sometimes facilities just hear the term HD, and that turns them off. So while yes, you do have to disclose HD, this is how HD is affecting my family member. The other thing I think that's important, it doesn't solve the problem of that long-term waiting. If you have a family member that's having significant behavioral issues, particularly that consulting with your Center of Excellence doctor or their community neurologist, if they're willing to get some help with symptom management, because that's often the biggest deterrent for facilities to accept folks. Now, I'm going to say something that might be a little controversial in this room, so I'm going to say this is my opinion. You know, I used to think we're going to go to that one facility that has the national expertise in Huntington's. Well, sometimes that's not available. I have found many smaller community facilities like adult family homes that had never cared for someone with Huntington's disease who were willing to partner with us. And with our Center of Excellence, one of the things that we did was we provided education for the team. We provided consultation. We assisted with symptom management. And sometimes that doesn't seem like, is that something we even want to try? They've never heard of it. I've had to educate everybody my whole life about HD. I'm tired of it. But you are the champion. You are the warrior for education, and it's still going to continue, you know. And so anything that you can do, because there are a lot of new facilities out there that are looking for residents. It may not always be the answer, but again, contact your chapter social worker, your Center of Excellence social worker, your support group members if you belong to one, because sometimes we can find things through those avenues too. I hope that helped answer part of that. It's tough, but I say early planning is best, yes.
I'm just surprised that they're getting responses that will help people do it. That's just the way they are. But those facilities are more likely to accept Huntington's disease because they had experience with outbursts.
So some great comments. One is that certainly now that we have seen some improvements throughout this long phase of COVID, that there may be more space in some nursing facilities. Oftentimes it may be hearing this is HD, and it scares people off. So don't always go by the 5-star rating. You know, I included that nursing home compare where homes are rated. Look for homes that also offer care, that have behavioral care experience, are willing to take people who may have some behaviors that aren't completely managed. And again, I say this in addition to what you said, be willing to provide the education. Find out if your Center of Excellence staff will partner with you. And those are some great ways to see what else is out there. Jimmy, go ahead.
I just comment on waiting list. I say this as a former nursing home administrator. Some states have law
K rate.
so that's exactly what gets considered at the morning meeting.
Well, we have a great conversation going on, for those of you who aren't in the room with us, about waiting lists. Some states have mandatory regulatory waiting lists. Others have a waiting list, quote unquote, and those decisions are made based on a variety of factors, everything from referral sources to whose care needs they can accommodate, to what's pressing on any given day. So again, I think the takeaway here is start early, look carefully, communicate, talk, listen, pay attention. It's going to change over time what someone's needs are. I can't say anything different than that. However, the more you can become an informed advocate, the better. And like I said, I know we have some real experts in this field sitting right in this room. So thank you all for sharing. We're past the 4:30 hour. It's been a delight to have you. I hope you've got some good takeaways, and these will be available in a week. Thanks very much.